Welcome all to my YouTube channel Medicine Made Easy. Today we will uh, study about hyponatremia. The contents of this presentation will be definition, what is the etiology, clinical features of hyponatremia, what are the diagnostic approach, and what is the management of hyponatremia. So by definition, a serum sodium level less than 135 milliequivalent per liter is called as hyponatremia. It is seen in 1.5 to 2.5% of hospitalized patients. It is rarely seen in OPD patients. And hyponatremia usually means not sodium deficiency but more of water retention. It can be classified as mild like 130 to 135 milliequivalent, moderate from 125 to 129, severe less than 125 milliequivalent per liter of sodium, and critical it is less than 110. It can be also classified according to duration of the hyponatremia. It is acute in less than 48 hours and chronic when it occurs after 48 hours. Etiologies. First, we have to rule out pseudohyponatremia. So the causes are with normal osmolarity, hyperlipidemia, and hyperproteinemia, and with high osmolarity, that is hyperglycemia and or mannitol. Hyperglycemia and use of mannitol can present as pseudohyponatremia. Rise in blood glucose over 200 for each 100 milligram of rise in blood glucose over 200, there should be correction of 2.5 to 3 milliequivalent per liter of sodium. Another is hypoosmolar hyponatremia, also called as true hyponatremia. It can be divided again into hyponatremia with extracellular volume depletion, yeah, which can be of two types, extrarenal loss or renal loss. In extrarenal loss, the urinary sodium is less than 15 milliequivalent per liter. That is, other than the loss of sodium is other than renal cause, like vomiting, diarrhea, and peritonitis. And if it is renal loss, there is urinary sodium is more than 20 milligrams per liter. It can be seen in excessive diuretic, salt-losing nephropathy, diabetic ketoacidosis, and cerebral salt wasting syndromes. Hyponatremia can be with hypervolemia or increased extracellular fluid volume. In this, if urinary sodium is less than 20, it is due to congestive heart failure, cirrhosis, and nephrotic syndrome. If urinary sodium is more than 20, it is due to renal failure. Third is hyponatremic with normal extracellular fluid volume. It can be seen in SIDH, postoperative pain, hypothyroidism, glucocorticoid deficiency, psychogenic polydipsia, and drug induced. These are causes of acute hyponatremia. It can be iatrogenic, postoperative, administration of hypotonic fluids, post-ERP, uterine surgery after colonoscopy preparation, recent use of thiazides, polydipsia, MDMA injection, exercise induced, and can be multifactorial. Example thiazide and polydipsia. What are the clinical features of hyponatremia? Again, it can be divided into mild, moderate, and severe as told previously. Mild is 120, 130 to 135. And in this, we can see symptoms like anorexia, headache, nausea, vomiting, lethargy. Moderate is 125 to 129 milliequivalent per liter of sodium. This can present with personality changes, muscle cramps, weakness, confusion, and ataxia. And severe is less than 125. The patient can become drowsy with diminished reflexes, convergence, coma, and in critical, that is less than 110, it can even lead to death. What is the diagnostic approach for hyponatremia? First, we have to assess the volume status. If it is hypovolemic, there is decreased water and also decreased sodium. Then we have to calculate urinary sodium. If it is more than 20 means it is renal loss, diuretic excess, mineralocorticoid deficiency, salt losing deficiency, renal tubular acidosis, metabolic alkalosis, ketonuria, osmotic diuresis, or cerebral salt resting syndrome. If urinary sodium is less than 20, it is due to extrarenal loss in the form of vomiting, diarrhea, third spacing, loss of fluids, burns, pancreatitis, trauma. If there is U volume where there is no edema, total body water is more, the total body sodium is normal. Here, if urinary sodium is more than 20, causes are like glucocorticoid deficiency, hypothyroidism, stress, drug-induced, or syndrome of inappropriate antidiuretic hormone secretion, that is SIDH. So SIDH is the cause of normovolumic hyponatremia. Now, if there is hypervolemia, that is there is edema, there is total body water is more as compared to total body sodium. Here again we have to calculate urinary sodium. If it is more than 20, it is due to renal failure. If urinary sodium is less than 20, causes like nephrotic syndrome, cirrhosis, and cardiac failure have to be seen. In this way, we can find out what is the cause of hyponatremia. So, as I told, one of the causes of hyponatremia is SIDH. These are all causes of SIDH, which can be malignant diseases and pulmonary disorders, disorders of central nervous system, can be drug induced, and, and also other causes. So, malignant diseases like small cell lung carcinoma, GI malignancies, can present as SIDH. Sometimes infections, pneumonia, viral pneumonia, tuberculosis. These can present like SIDS, even cystic fibrosis. Disorders of CNS like meningitis, encephalitis, brain abscess, even subdural hematoma, subarachnoid hemorrhage, CVS, cavernous sinus thrombosis, even multiple sclerosis, Guillain-Barré syndrome. This can present as SIDH, and drugs which can cause SIDH are SSRIs, selective serotonin reuptake inhibitors, tricyclic antidepressants, carbamazepine. So you should be careful when someone is using these kind of drugs which can precipitate hyponatremia, cyclophosphamide, oxytocin, vasopressin. These are some examples of drugs. Other causes like hereditary mutations in vasopressin receptors can be idiopathic, endurance exercise, nausea, GA, pain and stress. Diagnostic criteria for SIDH are there should be normal volume, but there should be absence of hypotension, dehydration. The urinary osmolarity should be more than 100 milliosmol. There should be high urinary sodium, more than 20 milliequivalent per liter, and we have to rule out hypothyroidism, hypoaldosteronism, and renal failure or diuretic therapy. What will be the management of hyponatremia? The dictum that we should remember is hyponatremia which develops quickly. It is acute. Within 48 hours should be treated fast. And which develops slowly, that is chronic. That is more than 20 48 hours. Should be corrected slowly. Treatment of hypovolemic hyponatremia is salt and water supplementation. If there is hypervolemic hyponatremia, then you should not administer salt. Treatment is water restriction and diuretics. If there is normovolemic hyponatremia, again treatment is water restriction. We should address specific treatment like removal of drugs causing hyponatremia like diuretics, cyclophosphamide. Then, as I told, basic principles we should follow in acute symptomatic or severe hyponatremia needs prompt and rapid correction, but chronic more than 48 hours and mild hyponatremia should be treated using slow acting therapy such as fluid restriction. You can wait and watch. Rapid correction, because rapid correction can lead to central pontine myelinosis or osmotic demyelinating syndrome, which are the complications of rapid correction of hyponatremia. This syndrome is characterized by dysarthria, dysphagia, flaccid paresis, or coma. So correction should not exceed more than 8 milliequivalent per liter in a given day, and treatment should be stopped when patient's symptoms are abolished or a safe plasma sodium is 120 or more than 125 is achieved. There is a method for calculating sodium requirement. The formula is sodium requirement is equal to desired sodium minus actual sodium multiplied by total body weight. A change in serum sodium concentration by a given IV fluid can also be calculated by a formula infused sodium per liter minus serum sodium divided by total body water in liters plus 1. Total body water is 50% of total body weight in females and 60% of total body weight in males. Since sodium concentration of IV fluids are 7.5%, sodium bicarbonate contains 900 milliequivalent per liter. 5% NaCl contains 1,855 milliequivalent per liter. 3% NaCl contains 513 and 0.9% NaCl contains 154 milliequivalent per liter of sodium. So we'll understand one by example. If a patient's sodium is 110, his weight is 80 kg, sorry 60 kg, and if we plan now to correct this sodium, patient is dehydrated, is hypovolemic, is hypovolemic hyponatremia, and if we plan to give 3% NaCl, then change in sodium we have to calculate by formula as told previously, infused sodium per liter minus serum sodium divided by total body water plus 1. Here as infused sodium we have taken 3%, it contains 513 milliequivalent per liter. So 513 minus patient sodium, that is 110, divided by total body water, that is zero point 0.6 into 60, is male patient, plus 1, uh, that is it comes to 403 divided by 36 plus 1, that is 403 divided by 37, it comes to 10.9 milliequivalent per liter. So to raise 10.9 milliequivalent per liter of sodium, 1 liter of 3% sodium chloride is required. In this way, we can calculate the amount of fluid that is required to raise desired sodium, and we have to repeat. In case of symptomatic patients, we have to repeat serum sodium every 4 to 6 hourly and change the fluid infused accordingly, change the rate of infusion accordingly. Treatment of SIDH is again treat underlying etiology, water restriction, avoid hypotonic fluids, hypertonic saline, diuretic like furosemide, and drugs like demoxycycline and lithium can be used. Thank you.